Thank you very much. Probably my presentation will be the last in today, so I really appreciate that you're here and want to listen. How it was told, I work in the National Health Fund, and what I would like to show you is our last project, primary healthcare pilot program for the primary care doctors from the biggest team, because now in Poland the basic primary care it's sometimes only GP, sometimes it's GP plus midwife plus nurse, but they work very often separately, and when the patient comes to the primary care, if would like to continue the healthcare service, just get the referral to the specialist, and of course have to wait for the another visit in different part of the system, because we as a National Health Fund, we contracted also separately with different part of the healthcare market, because we have separate contracted with the GPs, separate with the specialists, and also separate with the hospital. So a few years ago, we started thinking about the coordination, and we've got a lot of discuss what we should to coordinate it, and what should be the first stage. We thought that the best option is it will be start from the beginning, from the place when the patient comes for the first time. So we added to this basic primary care two very important components. First is the preventive checkups, and I would like to describe this part, and also the disease management element for the patient with the chronic disease. Because how we observe in the whole country and also in Europe that the citizens goes older and older, and a lot of them have chronic disease. So we need something different mechanism for them. And I can say that this pilot is a little bit bottom up. It's a variation from bottom up, because we discuss with the providers when we when we were planning this project, but this is organized and financed by us, and also by from the European funds. The project started in July 2018, and now we've got the information from the Ministry of Health that we could extend this project till December 2021. We organized this project in the whole country, and this is good and this is bad, because probably it will be better if we could concentrate this pilot in one region of Poland. But in European papers was written that we have to do it in every regional in the voivodeship. So this is how we have to do it, and we do. The providers cover more than 300,000 patients in their clinics. So this I think it's not small, but a medium pilot program. And for whom is the checkups? First of all, for the patients who comes to the primary care, but especially for people between 20 and 65 years old. In the best case is when the patient didn't use the healthcare service in the last 12 months. So we try to find people who didn't use the healthcare service, and we try to convince the providers that they should to start to stratificate their populations and get the knowledge about who and how the condition is of the patient which they covered. And how the paths of the checkups looks. First of all, the team of the primary healthcare should be very engaged, because they have to first qualify and then recruit the patients, so they have to do it actively, should to call them and invite to the visit. The patient should sign the consent. If he or she didn't do it, this is the end of this program for him or her. And then we can divide these checkups into two parts. First is a basic for everybody, and in these basic checkups we offer the set of 5 main popular diagnostic tests. It's morphology, ESR, reunion glucosis, and lipidogram, and this is the set offered for everyone. And then the doctor, sometimes the nurse could start, but the doctor finish the questionnaire balance. I skipped to another slide to show you what's inside this questionnaire. And what is the main idea is to fulfill this questionnaire together with the patient. There's a lot of questions, but we want to collect the information not only about the condition, but also about the previous health history, about the participation in the screening programs, preventive programs, because we as the National Health Fund offer a lot of them, but only 5–7% use these programs. In this questionnaire, the doctor or nurse should collect information about the medicine, about vaccinations, about the family story. I mean, family story, it's, for example, the chronic disease in the closest family members. And after fulfilling this questionnaire and after the physical examination, the doctor decided this is the end of this checkup, and send the patient, okay, you can come after 5 or 3 years, everything is okay with you and you've got the status 1. Or if the doctor recognizes some risk factor, could refer him to the extra diagnostic, and this is what is different between what is now in the basic primary care in this project, that if the GP referral the patient from the program to the specialist, this is the team of this primary care GP, because we pay directly to the GP and GP pay to the specialist. So the patient a little bit skip the clue, because the GP work closely together with this specialist who's he hired. Of course, the result should be in the electronic version, and the specialist and the GP and the team of this primary care should exchange the data from the patient for preparing the patient summary. This is something new because, how I mentioned before, when the patient comes to the GP now, it's probably the one contact and then move to the specialist. Now, when we GP prepare to the patient summary and the plan for the next visit, next educational part, the patient knows exactly what to do in the future. And this is also the small element of the management of healthcare by the patient. I mentioned that also after the checkups, the doctor decided what kind of status has the patient. So we propose 4 status. First is healthy, no risk factor, so you are really healthy and nothing happened with you. But sometimes if you have maybe a little bit BMI, the GP could send you to the educational visit. So you are the status 1, but still you can use the extra offer from the educational packet. The second status is healthy, with some risk factors. 3 is chronical ill but stable, could be conducted by the GP. 4 it's chronical ill, requiring the stabilization. So sometimes it might be done on the primary care level, but sometimes the patient should go to the specialist and also skip the program. Okay, maybe I should emphasize that the educational visits are very, it's something new here, because I can say that it's a set of the visits, because after the checkups, the patient come to the healthcare educator, and after 3 and 6 months, he will come to the supervising educational visits. So somebody plan for the patients what he or she should do, but after 3 or 6 months, it's checked that the patient do what he should do. And here, this is the example of fulfilling questionnaire, just to show what the patient get. And what is also new and important, that after printing this patient summary, the patient should sign that he agreed with this plan and try to do it. And we also started to monitoring the results. We just beginning this pilot because first agreement with the providers in the project was signed in July 2018, but till the end of 2018, 8,300 extended checkups were done, and also 1,700 basic checkups were done. So we are in the beginning. I hope that we conduct new components for the primary health care, and probably on the next ICIC conference I could say more what was the result, and we also will have the survey what the patients think about this new solution, and they agreed that it's something important and useful for them, or they like the previous system. Okay, thank you very much.
Thank you. So, We have some time for questions. Is there a microphone? Okay, microphone back. Anyone who wants to address one of the topics discussed here? Yeah.
Thank you. That was some great talks. It's Shelley Bick. I'm from Alberta Health Services in Canada. So I have questions for a couple of you. Dr. Kazimaki, I'm sorry if I didn't pronounce that right. In your model that you put up with that chart, I took a picture. It was quite interesting. It looks like you have one overarching management authority, and underneath that you had all your services, including primary care. I'm just curious, does that include your primary care physicians report up to this authority as well?
Yes, so it's in Finland, particularly in the public health services, the physicians are salaried employees, so just like other professional groups. So they are really in the organizations. They are not just consulting the other professionals. So it's that's
wonderful. So it brings you a lot closer to that integration step. Yeah, fascinating. Thank you. And then I had a question for the clinicians from Toronto. You had mentioned about your physician database, and you said you were having trouble with getting access to that. I guess two questions, maybe, depending on what the answer is to the first one. When you said physician database, do you mean a database of the physicians, who they are, where they are, their gender, how long they've been practicing? Yes, is that what you're referring to?
And whether or not they're doing comprehensive primary care.
Oh, okay. So that's
and where their practice is.
Where? Because in Alberta, our College of Physicians has almost all of that, except the last piece.
Yes, we do too, but they wouldn't share it for privacy reasons.
Your college wouldn't share it?
Yes, that's correct.
Okay, thank you.
Yeah. To the right, to your left. Okay, yeah, thank you.
Hi, Nicholas Hicks from Optimatis Clinic in the UK. It's just a quick question. I was just reading the strapline of the conference, evaluating and implementing models of integrated people-centred services. And each of you have described some quite significant service change. My question was, did any of you involve patients and citizens? And if so, what difference did it make?
We did. We have a citizens advisory panel, both at the regional level and at the local level. And so many of our initiatives we brought to the citizens panel for input, and that we actually revised our strategies based on their input.
That's for Toronto.
How it changed, how the involvement changed what you thought.
So I'll just give you one example. We were planning to have a patient survey of the discharge summary process. So we had the patients write the discharge summary questionnaire to patients. What was important to them in the discharge summary process, and we're just piloting that to roll it out. We developed a coordinated care plan, and many patients were involved in what that looked like. So we try to bring as many things as possible to them.
Yeah, I don't know, some complementary answer?
We didn't really. We didn't have a choice.
You didn't have the choice, yeah.
But we did explain to them what we were doing and why. So,
yeah.
But we didn't have the luxury of planning it a long time in advance.
Okay, yeah. Any other question? Yes.
Hi, thank you. Sarah Thomas, Public Health Wales. Thank you everybody for some really interesting presentations. My question really relates to the last presentation, a colleague from Poland. In terms of the uptake of the check that you were offering, I didn't quite get from the slide what level of uptake you were getting, percentage of people who were invited who attended. And in response to that, have you looked at the uptake according to deprivation? So are there differences in the level of uptake across deprivation?
I'm not sure that I understand you correctly.
So the first part of the question is the level of uptake.
Uptake
of the proposed checkups.
But so of the people invited, are you getting many people taking up the offer, so coming for the health, for the check?
Now Still, I'm not sure that I understand your question, because you ask about the uptakes.
Uptake, which means
update.
It's offering. There is an offering of checkup to the people. To what percentage do people effectively have the checkup?
Okay, so we say that the limit for the active checkup should be 30% of this population. 30. But I showed that 300,000 people are covered, but not all of them are the participant of the checkups, because checkups are from the patient between 20 and 65 years old. So the third percent from this group.
But is it going in the sense that you are reaching the 30% objective?
We would like to achieve this limit, but we are not sure that it's possible because at the beginning the project was for 2 years. So half a year we need for not only we but the providers need time to learn how to organize the practice, how to invite the patients for the checkups. Especially the biggest problem was how to convince patients to come second or third time for the especially educational visits, because patients want to prescription and referral and go. But now when we have the extension of the project, I think this is the chance to achieve this 30%.
So, wait and see and have the follow. Yes? It's okay, you can use it, yeah.
I give some answer as a provider of this project, because my center do this project. So it's, this is something new in our system to invite the patient for the checkups. It still have the scientific board have some not very sure about this method, but our centers are quite divided. Some of them are quite well prepared, so they made before some invited people for the prophylaxis. They can manage better than this will start on the beginning. So nowadays we have probably some of them are about 10–15% of the population is invited, and some of them more than 30–35% now. Okay.
Okay, thank you. Any other question? No. I think we are getting a bit tired. But this was I find it a very interesting panel, and would like to thank you very much for your contributions, and thank you for attending here. Enjoy the drinks, and see you back tomorrow. So give them an applause. Thank you so much.